Good afternoon, everybody. Thank you so much for being here, being part of this Echo series. My name is Lindsay Winters-Jewell, and I'm a program manager here. You are joining our Alzheimer's disease and related dementia series. So today, here's our order of events. We're going to start with our knowledge burst presented by our panelist, Audie Black. The topic today is managing cognitive health in primary care, early detection and intervention.
Thank you all for the opportunity to be here with you. And one of my deepest fears as a speaker is always that I'm going to share something that everyone already knows. And so if that happens, just enjoy a light lunch, but hopefully there's something of value for each of you today. We're going to be talking about managing cognitive health in a primary care setting and really focusing on two ends of early detection, but also early intervention. And again, I know this is a huge challenge in our communities, especially with how rural of a state we are, and that a lot of mild cognitive impairment and dementia is managed in our primary care settings rather than specialty settings. So I hope this is of some value. Let's go to the next slide. And really, today I want to tackle a few key things, and we have about 25 minutes. One, I want us to understand some of the strengths and weaknesses of the different screeners that are out there, and we're going to focus on three of the most common and widely used screeners and when you might use each of them and why. But I also want to talk about what do we do with the data, because everyone's familiar with, taking the cut score that's printed on the measure. But what I see a lot of times is that we're inflexibly applying those cut scores, which is not how it's designed. And I want to give a quick example of the danger of doing that when we look at things like base rates of MCI and dementia and how the meaning of those scores actually changes depending on your setting. And so we'll dig into just a little bit of stats. I'll try not to bore you, but I do think the concept and principle is very important when we talk about screening in settings like our primary care settings. Then we'll discuss if we have a positive result, what are some recommended next steps? And here I want to tread cautiously. Again, I'm approaching this from a neuropsych perspective, and I realize there is a broader perspective that's out there, but I'll share some insights from what I've learned over the years of things that can be helpful. And then I want to do a little bit deeper dive into some evidence-based interventions for MCI specifically. So for those of you that may not be familiar, mild cognitive impairment or MCI is considered in many ways to be a precursor to dementia, but we're not quite at a dementia. And so what can we do at that stage if there's a positive screening result, as that is a much larger number of folks than those who will actually go on to develop dementia itself. Next slide. So I'm an Idaho native, born and raised here, multi-generation, and this is a topic that's of deep interest and passion for me. I have family all over the state, from Boise to Cottonwood and kind of north central Idaho, all the way over to eastern Idaho. And a lot of my family lives in rural settings and farming and ranching communities. And this is a really urgent issue that all of us are facing. We have a rapidly changing population in this state, and I presume you all know this, but if not, it's pretty eye-opening. One, we actually just broke 2 million as of earlier this year's the official population estimate for 2025. But what's striking is the percentage of people who are 65 and older. And it's actually the fastest growing demographic segment of our entire state. And if you look at the infographic on the right that comes from USA Facts, what's interesting is in 2010, if you see, and I know it's maybe a little bit hard to read on the screen, but that dark blue segment that's around the 10 o'clock position, we had about 12.5% of our population in 2010 that was 65 and older. But notice that by 2022, that had actually grown to 17% of the population. This is one of the largest swings in the country across all states, and Idaho is aging like everywhere, but our percentage of the population that is aging is growing dramatically as people retire here and move here from other states for the quality of life. And so the care needs are increasing dramatically, and yet the number of providers to service this group has not grown proportionally. Let's go to the next slide. When we look at the scope of the challenge, so those are just basic demographics of our state, rapidly aging, and that percentage of our population is growing. The question is, well, how many people here are living with some type of Alzheimer's disease or related dementia? And we have some local stats, which I'm sure you've all seen, but if we're going to extrapolate out from some of the best studies that we have, arguably the best comes from Manley and colleagues, published in JAMA Neurology in 2022. And what's really lovely about their study was they look at a nationally representative population and they did extremely rigorous diagnostics to figure out who is a normal aging population versus MCI versus dementia. And using those figures and applying it to Idaho's population specifically, we can pretty accurately estimate that about 33,000 Idahoans are living with a dementia of any type. And I think that number seems familiar to all of you from what's being put out by the state. However, notice that over 73,000 more Idahoans are living with MCI. And so when you combine that, we're well over 100,000 of our neighbors and colleagues dealing with some degree of meaningful cognitive change in older age. And this puts enormous pressure on our primary health clinics. Next slide. So we know we have this crushing need, and it's an increasingly urgent need to identify these individuals. The question is, how do we detect it? And of course, in a primary care setting, we are often dealing with higher volume clinics, right? So we need to move quickly. We need something that's accurate, that's efficient, and that can be administered by trained staff to help cases moving along, whether it's a medical assistant or an RN. Oftentimes, these tools are going to be administered by someone other than the main provider. There's many different options out there, but arguably the three most common and widely used are the slums, the MoCA, and the MMSC, as all of you know. The thing I want to highlight, and I realize you may not be able to choose which one you give, your institution may dictate that for you, but let's hypothetically say you're on an advisory committee for your institution, or you're in a practice where you do have more control over which measure you give. We really want to understand that these tools are very different and they have strengths and weaknesses. And I'm going to start at the bottom really quick with the MMSE, which is the most widely used cognitive screening tool in the world, or was. It may have been surpassed at this point and has been around for decades, has an excellent research base. MSE is great. It's super short, 5 to 7 minutes. You can do it by memory. You don't have to have hardly any stimuli for it. And again, well validated for Alzheimer's disease. The issue is it's well validated for Alzheimer's disease. It does not do a great job for detecting other types of dementia, including specifically vascular disease or Lewy body pathology, things that involve more processing speed deficits or visual spatial dysfunction. It does not do as good of a job there as it does for Alzheimer's disease, which is what it was originally designed for. It also does not do as good of a job at detecting more subtle impairments or things like MCI, or even the earliest stage. And so it's a good tool, but only in the right context and with the right population. The two that I'm going to argue are probably better for more widespread adoption are the slums and the MoCA. Now, the MoCA obviously takes a little bit longer, a few extra minutes, which matters in a high volume practice, but they both have been shown in the research to be more sensitive to both MCI, but also non-amnestic type dementias like your vascular dementia, your Lewy body pathology, some aspects of FTD, frontal temporal dementia, although not all, but they are more sensitive to those. And so go ahead and go to the next slide. So before we get to kind of final recommendation, I just want to talk a little bit about stats, and forgive me because I know most people's eyes glaze over, but this stuff's super important when we're looking at which tool do we choose. And again, picture you're on the advisory committee of your practice or of an institution. How do you choose the tool? Well, first of all, you're going to look at the basics of their sensitivity and specificity. And remember, sensitivity and specificity, when you look up those stats, which are widely published on all these tests, those stats are based at a group level, meaning, let's say I take 100 people in the community with 50 of them who have known validated dementia of a given type based on a gold standard diagnosis. Usually it's a comprehensive multidisciplinary diagnosis. And we're comparing that to this specific tool, like the slums or the MoCA. At a group level in the community, how sensitive is our test, like the slums or the MoCA, at detecting that dementia versus how specific are the results? So those are group level stats. But in a real world clinic, you're not talking about a group level population health perspective. You're talking about the person in front of me. Sally or Don are sitting right in front of you. You give them the test and you get a score, and you want to know, well, how accurate is this for determining whether they have MCI or dementia? And that situation, you're really relying on two stats. You're relying on your positive predictive value versus your negative predictive value. And what's vital to understand is that those stats actually vary based on the prevalence rate of dementia in your clinic. And so if you're in a PCP practice that has a lower rate of dementia than, say, Dr. Kuntz's memory clinic, the same cut score will actually give you a different answer. And again, we don't talk about this enough. And I want to just share a stat with you, ran some stats on it really quick. If let's just say you have a test like the MoCA, and let's assume it has a 90% sensitivity and a 75% specificity. That's pretty accurate with the standard cut score of 26. Sounds really good, but look what happens when you apply it to a base rate. If you're in a PCP practice with, maybe you're in a very general PCP practice and you have a 5% base rate of MCI and dementia, meaning across your 3,000 patients, 5% meet for this diagnosis. Your positive predictive value for a person who scores below the cut point is only 16%, meaning they get a positive screening test on the MoCA. The probability they actually have a cognitive issue is only 16% in that setting. You give the exact same test with the same cut score in a memory center where 50% of the people at minimum are going to have cognitive issues, probably higher. Your PPV actually goes up to 78%. The takeaway I want to give, this should raise anxiety a little bit, is we have to understand these tools. They do not work the same way, and the scores do not mean the same thing in all settings. It's highly dependent on your patient characteristics and your base rates. And we can talk more about that. And I put some info on the slides here. So in a primary care clinic, the way to think about it is if they pass the screening test, you can have a higher degree of confidence in that result than if they fail it. And so it's reassuring if they pass it, not 100%, but it's more reassuring. But a positive result, I'm going to question, and that's where we need some further workup. Let's go to the next slide. So in a PCP practice, what I'd recommend, use tools with high sensitivity, like the MoCA or the slums, to minimize false negatives, but recognize you're actually going to have a higher percentage of false positives. So we have to remember these are screening tools. These are not diagnostic tests, and they were never intended to be used diagnostically, even though many providers do. That's not how they're intended to be used. It's a screening test to determine, do we need further workup or not? And at the early stage, I would argue we should cast a really wide net. We want to capture as many people who might have a problem as possible so we can get them onto further workup rather than missing people who have a legitimate interest. The one PSA announcement I'll make at this stage is, please make sure your staff who's administering them have gone through formal training on it. It's widely available online. In most cases, it's free, but they need to be trained in how to reliably and validly administer these tests. And I've seen some pretty wild stuff when I've seen these tests used in the hospital settings and in rehab settings, where the results are absolutely not valid, but they get interpreted as if they were. So please make sure staff are trained and are up to standard. Let's go to the next slide. So I trust everyone knows this, but just another piece is that the cognitive screeners are just one piece of data. It's a really important piece of data. It's often our only objective assessment of functioning. But I would argue what's as important, in some cases more important, is assessment of daily functioning. And of course, we're going to look at our IADLs first. They're the more complex ADLs that require higher level cognition, and it's where you're going to see problems first. And We know that for people who are highly educated and work in cognitively demanding occupations like attorneys, CPAs, physicians, healthcare providers, engineers, they can look fine on a cognitive screening test, but you'll start to see issues with the IADLs first. And that's often our very leading edge indicator that there's an issue. And so please look at the IADLs, and there's some validated tests out there like the 88 or the FAQ if you want a validated standardized assessment that are free to use in your clinics, or you can just do it through a semi-structured interview. It takes just a few minutes, but is a vital piece of info. Go ahead and go to the next slide. I'm also going to argue that whenever possible, we need to get collateral input, and that's because significant percentage of individuals, depending on the type of dementia. So I'm I'm generalizing here, but MCI and dementia, broadly speaking, there's a significant percentage of individuals who have limited insight into the fact that they're having significant changes. And the Greek term, the anosognosia, is very striking in many cases. And so the person may feel like things are completely fine, but their family members around them will be able to provide a more accurate, nuanced perspective in many cases. Now, again, there are other types of dementias where the person themselves will have a high degree of insight into their cognitive change, and they may be concerned before their family members. But as a general rule of thumb, I strongly recommend getting some collateral informant about, look, are there concerns? How significant are they? Where are we seeing the issues? Just to, again, start to triangulate some data on how big of a concern are we dealing with. Go ahead and go to the next slide. So what do we do? Let's presume we have a positive screening result on the slums or the MoCA. We've talked with family. They share some observations of change. They're also beginning to become concerned. We assess IADLs, and we know that we're starting to see some issues with reliably doing the IADLs, like managing finances or managing medications. What do we do? Well, if it's a positive screening, broadly speaking, I'm going to argue we need to start to gather more info about the timing, the progression, alleviating and exacerbating factors. Again, always look for reversible causes of these changes, depending on what they're reporting to you. So running your basic labs, looking at medications that can be contributing, looking at mood or sleep factors. And again, you can give assessments there. And then you're starting to think about, okay, what resources do we have? Can we refer out? And I realize this part I always am very sensitive on. It's very different in a place like Boise or even Magic Valley than it is if you're in where my family is, Cottonwood, or in rural eastern Idaho or up in Coeur d'Alene. But if you have geriatrics available, or neurology available, or neuropsychology available, one of those three often can be a next step for diagnostic confirmation, depending on the case and what resources you have. And we could talk about that. And then we're going to start doing some education with the family, preparing them that there may be a concern here that we need to address. If it's a borderline score, I'm going to clarify who is concerned and how big are the concerns. And then we might start screening for other contributing factors again that could be contributing to this. For instance, untreated sleep apnea, untreated hearing loss, etc. And then start to really vigorously go after lifestyle modification factors to see if someone responds to that intervention and actually demonstrates improvement. And then, of course, rescreening at regular intervals. And if it's negative, it depends on who's concerned, how significant. But again, modifiable risk factors, monitoring if they're considered at high risk, and then providing some reassurance. Or if they're a higher achieving professional, highly educated, and you just, that hair is standing up on the back of your neck, and you say, there's a bigger problem here than what the test is showing me, then it's probably going to be a referral to a specialty clinic for further workup. Go ahead and go to the next slide. So I debated about putting this in. I'm going to do this really fast, but I realized there's always a lot of questions about what role does neuropsychology play in this, and there's a lot of different feelings out there, all valid. I'll share with you my thoughts and impressions about when it can be helpful, when it's not, but let's get into it really quick. Next slide. I'm presuming many of you are familiar with these consensus statements that really guide a lot of this work. So, for instance, the United States Preventative Services Task Force, they publish every few years their updates on what is recommended in primary care practices for screening for cognitive impairment. And it's this really rosy stuff, right? If you have a positive screening test result, you should do additional testing. And notice it says, and a medical and neuropsychological evaluation. I love that. It presumes everyone has access to these things and there's no barriers, right? Everyone should get this gold standard. But of course, the reality is more complicated. The American Academy of Neurology recommends something similarly, that they recommend a more comprehensive neuropsych assessment when there's ample evidence for concern. But again, presuming that's available. Let's go to the next slide. So here's my take on it. Okay. Thinking about Idaho being a very challenging state, we have very few resources. Who should we reserve the gold standard of neuropsych testing for? I would argue this is a pretty good starting point. So if you print this slide and think about this, this is where I would personally recommend you start. If there's concerns of early onset dementia, we know that our screening tests are not nearly as sensitive for picking up concerns with this population. If there's concerns regarding atypical dementias, they are also not good at picking up these concerns. For instance, if you have a behavioral variant frontal temporal dementia, they will often pass a MoCA with flying colors. They may only miss 1 point. And even then, I've seen many of those cases that they get a 30 out of 30, and yet they absolutely have a progressive dementia. So again, you have to know your screening tests and their strengths and weaknesses. For challenging differential diagnoses, helpful. High functioning individuals, we've talked about that. Our tests will be much more sensitive than any other tests out there, including the computerized tests, which we'll talk about. And then if there's a real mismatch and we're going, what they're telling me doesn't match what I'm seeing on the data, it's a puzzling situation, but people are deeply concerned. And often there's some other secondary concerns like finances, business decisions that need to be made, etc. Neuropsych can provide some clarity to help address those situations. And then something I do a lot of, about half my practice now, is actually in the forensic arena. So extra clinical needs, whether it's testamentary capacity, contractual capacity, capacity for independent living, guardianship, conservatorship, all those sorts of things. That's when you're often going to get into neuropsych. Let's go to the next slide. When is it least helpful? Well, I think first and foremost, if someone's in acute delirium, absolutely do not need neuropsych. They're going to be globally impaired and it's a total waste. This is where an inpatient consult's helpful with psychiatry or neuropsych, but they're not going to do full neuropsych testing. People who are severely impaired do not benefit from full neuropsych unless there's an extra clinical need around things like guardianship or conservatorship. So again, if it's a clear-cut case, save the resources for everyone. If it's a clear-cut diagnosis, save the resources. If you can get everything you need from your screening test, talking with the family, and then doing some standardized assessment of functional capacities, I would say save the resources. And then this one is a little more controversial, but for our non-English speaking patients in Idaho, the challenge is, to my knowledge, we do not have any neuropsychologists that can do evaluations in other languages without using an interpreter. And an interpreter introduces a lot of issues with the interpretation of the data. We don't have good norms when we use interpretation. So the whole validity of that type of testing really suffers. And that's a longer discussion we can have if you want in the FAQ. But I would argue in those cases, I would really be cautious about referring for neuropsych unless there's a very, very clear need. Go to the next slide. So as we talked about, neuropsych testing is extremely resource intensive. It's time consuming, it's relatively expensive, and it's only one piece of the puzzle. An evaluation doesn't provide any treatment, it's an evaluation. And so a lot goes into these, and yet it's not always the right move. And I say that as a neuropsychologist. We want to get the right people in for testing at the right time where we can have maximum impact and save our powder in all other situations. And in Idaho, extensive wait lists at most clinics and there's often no neuropsych available in huge swaths of the state. So we have a real resource challenge there. And I highlight that given that the specialty guidelines say to do it. And yet it's often very challenging here. Next slide. So in an aspirational model, we would do annual screening on everyone over, let's say, 60, although I will tell you the specialty task force does not recommend that, but the American Academy of Neurology does, as do other organizations, generally recommend doing some type of standardized screening. I would argue that we should do a second tier screening if the first one's positive, and this would be more with computerized testing, things like Craos, Cantab Mobile, CNS vital signs. We can talk about some of those, but we have to realize they are still screening tests. They are not diagnostic tests. And so it makes me nervous when clinics are using them as if they are a gold standard diagnostic test. They're not. And the data and the own test publishers support that. But it is helpful to get a second level of screening to change your base rate so we can have higher confidence in diagnosis. And then if those are positive and it meets one of those other criteria, then you can send for neuropsych and then their serial follow-up at whatever level is appropriate. Next slide. If I had $10 million and I could do grant money, what I would invest in for Idaho is the second tier screening. This is what makes the most sense to me for our state with our population, our limitations. I think we could do a tremendous amount of good at more robustly developing that second tier screening stage in terms of being able to help support our primary care clinics. And again, happy to talk about that more if we wanted, but that's what's missing right now in all of Idaho. Next slide. So again, next slide. So we're back to primary care, and I just have a couple slides here. Let's say we confirm it's MCI. We're at that early stage. And I put in some suggested framing to patients and families, and I would love to hear how you talk about this with them. Essentially, what I do is I talk to people and I say, look, the good news is it's not dementia, but it is showing that there's more changes than normal for the standard aging process. So we need to pay attention. And there's a window of opportunity here where you might be able to make some meaningful impact and help either slow down or in some cases stall the progression of the disease. We know with MCI, some people, if there's underlying medical contributing factors, actually get better and can go out of MCI. And I've seen that many times. It's awesome, right? If they have untreated issues that get treated and all of a sudden their cognition significantly improves. Many people will stay at MCI. And then of course, about, depending on the stat you look at, somewhere around 10 to 15% of people a year with MCI will go on to convert into a frank dementia. But we have an opportunity there to do something about it. I also hope you're talking with all your patients, and I know we've talked about this at other echoes, highlight modifiable lifestyle risk factors. And this comes from the Lancet report that publishes their list of what we know can help decrease overall incidence rates of dementia by almost 40% if we focus on these modifiable lifestyle factors. Go to the next slide. I just am highlighting a few here out of that huge list. I think there's really 5 that can make a massive difference and that typically come up at this stage. First is routine, moderate exercise. I like to call it movement rather than exercise because it's less threatening to people who may be sedentary, but it's potentially, according to meta-analyses, the single most important lifestyle intervention we can make in terms of making the biggest bang for the buck on cognition. And I put in some info there to help guide that. For the sake of time, I'm going to go on to the other ones. The next one is a heart-healthy diet. And out of all the different lifestyle eating patterns out there, Mediterranean diet and the Mind diet have the most robust support for dementia specifically. And it's emphasizing plant-based eating, whole food eating with smaller portions of animal-based protein, and specifically trying to really cut out red meat as much as possible and focusing more on things like fish and skinless, boneless chicken, that sort of thing. And so anyways, we could go into a lot more on that, but focusing on diet. And then the last 3, and this is where we'll end, sleep becomes an issue, as we all know, in later stages of life. And so really looking at what's going on with sleep, what type of issues are we having, and can we optimize it? Are there any untreated conditions there that we need to manage? social connection is vitally important. People will start contracting socially when they start having these changes out of fear of embarrassment, also due to the co-accompanying mood concerns and sometimes anxiety that comes along with these cognitive changes. And so we have to really push people to remain socially active. And we know it's a meaningful intervention on many levels, biologically and psychologically. And then hearing loss has been identified by the Lancet Commission as probably one of the most potent modifiable risk factors for later life dementia, although the evidence on this is variable depending on the study, but we know it's vitally important. So if you're hitting all the other ones, make sure you're also hitting hearing and doing hearing screening and then referring to audiology as needed. With that, I'm going to wrap because I know I went just 2-3 minutes over. Do you want to do a quick discussion now, Lindsay, or should we dump into the case? What do we have time for?
Yes, let's start. We have a question from Joelle. Let's do one question, and then I think we do need to move our question and comment to the chat. So thanks, Joelle. You mentioned that screening tests aren't as accurate in a younger population, but there have been established norms for different age groups, like standard neuropsych batteries.
Mm-hmm.
So oftentimes with the MCI cutoff, I can't see that part. Patients want to know if it's normal for their age group.
Yeah, it depends. It's a great question. I love that question so much because the norms matter. It depends on the screening test, but there are some age and education, even more education adjusted norms than just like adding the 1 point if they have high school or less education. There's some more sophisticated norms that are out there for some of the tests. For instance, the MOCA has more sophisticated norms that have been independently published by researchers, and it can make a dramatic difference on what cut score you use. And so, yes, the answer is yes. The MOCA has that. I don't know if the SLUMS has that level of data, and the MMSC absolutely has that data as well. But again, I don't recommend the MMSC for primary clinics, given that it's so memory dementia specific focus, and you're going to miss a lot of other types of concerns. So in this situation, I'd recommend MOCA.